cardiac surgeon, graduated from Riyadh University many years back and trained in the US. And I've been with the department for the rest of my life. Okay. So my slide is not working. I'm not sure really what's going on here. So the first question is, what are the principles of myocardial protection during cardiac surgery? And I would look at the list here and ask Hudayb, Abdullah, can you give us a clue here what we are talking about?
Please mute, everybody please mute the mic. Otherwise you'll hear a lot of echo. Doctor, are you asking me about to answer this question?
Yeah.
Basically, to decrease the, I would say, decrease the myocardial the demand and to arrest the, while arresting the heart, allowing good operative exposure and operative field to perform the surgery and decrease the myocardial damage.
I would define it as myocardial protection is the preservation of cellular viability with optimal timely functional recovery. And we're talking about myocardium, myocardial cells, endothelial cells, all cells that were involved. So just like you said, to perform a neat, timely surgery there. The basis for that is to minimize oxygen consumption by rapid induction of arrest using hypothermia, appropriate buffering milieu, and metabolic substrate preservation for the heart, in particular, in this case, the creatinine phosphate, and the minimize the intracellular edema, so the patient will have a good functioning heart for the next postoperative period. This is a graph that was published many years back in 1982 on experiment from rats. And it basically shows the percentage of heart recovery after 15 minutes of warm ischemia. And you can see that if the patient had completely warm temperature of 36, almost there's no recovery. As you go up here towards somewhere around the curve, around 28, you start having some 75% recovery. Around the 20 degrees, the curve flatten, and usually it's around 90–95% recovery. So this will show the effect of temperature on the preservation of the myocardial function after 15 minutes of ischemic insult. Another graph here shows the different type of temperature with different kind of functionalities on the heart. For example, in ventricular fibrillation, the myocardial function and oxygen consumption is the highest at the 37 degrees. It's much more even than the beating heart with full beating heart. In the cardioplegic arrest, it's much less. It's almost like somewhere around 1 mil per 100 milligram of, 100 grams of tissue per minute. As you go down with the temperature, you can see that the oxygen consumption decreases. But the most important factor here is the cardiac arrest. And you can see that have lowered it much, but also with hypothermia, we can even lower it much more. These are the actual numbers from that experiment. The view here is also illustrating that in patients who have on bypass, which are maintained on normal flow, which is 2.2 to 2.5 liters per minute. As you cool down the patient, you can lower that flow to 1.6 or so, 1.8 liters. So that's an advantage you can take as a surgeon to lower the flow, so you can see better occasionally during the time of surgery. The next few slides are a very basic information that every resident should really be aware of and maybe should expand their knowledge in that area. and which showing the disadvantages of hypothermia. How does it affect? It does affect the oxygen dissociation curve down with a shift to the left. And the message here is to optimize oxygen delivery at the time of bypass, as we call some of those patients. Increase blood viscosity, it happens. That's why we allow some hemodilution for those patients to allow for better circulation on bypass. There's a constriction of many of the vessels, and that's why we also recommend using some vasodilators during the procedure. Decreased coronary flow autoregulation, and therefore we have to maintain very good perfusion pressure if the coronaries are open, or if the patient is being arrested after surgery, the patient should have a good perfusion pressure for the coronaries. Positive inotropic effect, mainly because of the intracellular calcium increase, and also the changes of the pH neutrality, alpha stat, pH stat physiology, and strategy that's used during the bypass. Also, hypothermia can inhibit insulin release, as well as time to be taken for rewarming is very important, as some patients will have a drop-off afterward, and adequate rewarming with vasodilators may be used. Increase oxygen consumption by shivering in the immediate postoperative period. Make sure that the patient does not have that, so adequate rewarming is an important part. If it's a problem when the patient is desaturating or having major problem with his hemodynamics, neuromuscular blockade may be used. The buffer issue, many parts of the biological systems help with buffering the patient, and therefore hemoglobin, bicarb, phosphate, amino acids, and histidine and carnosine are all well recognized for that. I'm going to ask you guys here, let's see who's there, one of the seniors, maybe, or juniors. Ahmed Salboud, what does the word buffer means?
Buffering system is to to normalize the pH of the solution. I would say.
Okay, it's not necessarily normalize, but stabilize it at a certain point. And well said. So basically, when you use a buffer system, you are balanced. In addition, by adding more and more acid, you will have a period here where the buffering range will act perfectly and keep the pH around certain number figure that will stabilize. And usually that's referred to as the pKa. For example, there's one for hemoglobin, which is usually around 7.4, THAM bicarb is around 6.1, histidine 6.1 at those different temperatures. So each one of them, this number may change up and down depending on the temperature of the patient. It's a very important concept to understand. If you really don't realize that, go back again to the biochemistry and read about it, because it's a very important concept for understanding not only the buffering of the cardioplegia that we use, but also for other part of the hemostasis. So the different pH is very important for our recovery. The percentage of recovery is dependent on the pH that the patient have. So for example, if the patient heart is exposed to lower pH, the chances of recovery is about 20%. The chances of good recovery for the stroke volume or the cardiac output is about 20%. Around 7 pH of 7, it's about 80%. Around the normal, which is 7.4, is all approaching 100%. With higher, higher doesn't mean better. It's going to go back again, dipping down because of the alkalosis, severe alkalosis. So we aim for somewhere around normal pressure, somewhere between 7 to 7.4. The pH also is affected by the different content of the cardioplegic solution. For example, if you mix it with nitrogen, it has very smaller, much smaller chance of recovery, somewhere around 60–65%. While if you add CO2 to the nitrogen, 5% CO2, it becomes around 75. Or if you add only oxygen to the solution, saturating that solution with 100% oxygen, it's still around 75%. Adding oxygen and CO2 will give you the best combination, and that's because of the added value of CO2 to the buffer system. Substrate enhancement, there are a lot of work have been done, but this slide here reflects the presence of creatinine phosphate at different, as you decrease your oxygen consumption from 12 to 10, which is the normal range, down to 1 or 2 using the cardioplegia, you're actually preserving the creatinine phosphate. This usually reflects in a better recovery after surgery, as you have a good substrate for the patient for the heart to beat and have a good contractility. Adding ATP have failed, but other substrate have helped. Avoidance of myocardial ischemia is very important. So if you use isotonic solution, which is around 300, you will have probably the best outcome. We use for that inert sugar like mannitol, which you will find in many of the solutions that we use for cardioplegia. Sorbitol, glucose, and dextrose have been used. Also dextran and hydroxyl starches also have been used. And all of these aim to reduce the edema by improving on the osmolarity of the fluid that we use. If you use hyperosmolar fluid, what will happen? Let me ask this question. Khalifa, what will happen if I use hyperosmolar fluid? Okay, we'll go to Abdelaziz Al-Ghamdi. Can you all hear me?
Yes, doctor.
Okay, well,
Yes.
if you use hyperosmolar fluid or if you use hypoosmolar fluid, what will happen? What is the thing that will happen related to edema here, myocardial edema and myocytes situation? Let's ask Abir Al-Ghamdi. Okay, we'll go for someone else. Let's see here. Hussein?
The concentration between the electrolyte will different, so this will result in cell swelling or shrinking.
Exactly. So it's when you're talking about osmolarity, we're talking about water, and therefore the myocytes will either swell and develop edema, or it will shrink and develop dehydration. And that can, of course, affect later on the function of that cells. That's why we always aim for osmolarity close to normal, which is around 300. Okay. Not sure if we moved correctly here. Yes. All right. So another issue that we have is the production of free oxygen radicals. In normal circulation, that will be taken care of by the dismutase and other normal enzymes, NAD and NAD system. But when we have ischemia, we start having cells having higher concentration of calcium, which are will activate the enzymes, and the xanthine oxidase and hypoxanthine oxidase will also be higher, and therefore more and more production of free oxygen radicals in different forms. These forms can be dangerous as they go toward the end by producing hydroxyl radicals, which will reduce lipid peroxidation as well as protein denaturation. Among those, you can see among those free radical scavengers, which is naturally occurring in the body, vitamin E and histidine and glutathione, mannitol, allopurinol, all these things that can be used in our cardioplegia to help prevent the bad effect, deleterious effect of free oxygen radicals produced after reperfusion. If we have a problem with the myocardial protection, we may end up with low cardiac output syndrome. And again, for everybody in the group here, I think they should read and enrich their knowledge about low cardiac output syndromes in general. This is a very common problem. I shouldn't say that. It's a problem that you should be very well equipped to handle after cardiac surgery. So low cardiac output in the hemodynamic, it will be inappropriate. For example, reasons for that would be inappropriate preload, hypovolemia, for example, or inappropriate afterload, severe vasodilatation related to some medication maybe, or sepsis or whatever, arrhythmia problems that can lead to low cardiac output, high pulmonary vascular resistance, which we usually see in kids and infants, and it can lead to a disaster after surgery, especially if the patient is known to have pulmonary hypertension before, cardiac tamponade in the few days after surgery. All these can lead to low cardiac output. Metabolic reasons, hypoxia, hypercapnia, acidosis, renal insufficiency, coronary arteries embolization with either small air emboli around the coronaries, which can give you ischemia. The surgical causes may be myocardial ischemia, mainly poor perfusion related to infarction, stenosis of kinking of vessels or spasm, mitral valve surgery replacement affecting the myocardium or the endocardium or the coronary itself. Residual uncorrected cardiac defects, inadequate myocardial protection, and this is where today we're talking about here, the composite or the inadequate distribution or the rapid rewarming without good temperature control. Other causes can be pre-existing problems, allergic to some medication like protamine that has been used at the time of surgery, or even infection after surgery, urinary tract infection, retention. The function of the endothelium is a very important basic knowledge that every cardiac surgeon should be aware of. It's a multitude of things. They have written books on this issue, and I would advise you to read about it. This is a table here that will summarize some of the effects related to secretion of the, some of the effects that affect anticoagulation, inactivation of some medication like the ATP, ATP, and the binding of thrombin and fibrinogen effects. Very important concept nowadays in the corona business. They talk about the microcirculation thrombosis and the injury to the endothelium. Modulating of the inflammatory process also have been there manifestations of immunoreactivity, including the blood grouping and the molecular vascular tone, which is maybe related to nitric oxide. This slide may have been written before that time. The cardiac function and how does it relate to myocardial preservation is very important. In the first phase, we have a very the entrance of the rapid entrance of the sodium, and then the calcium, and then at the end, during the phase of recovery, the potassium through the potassium sodium pump. One thing is wrong about this depiction here of this graph. I'm going to ask, I'm not sure if Loai is there. Is Loai there? Okay, we'll take Ghada. Can you tell us what's wrong of this graph depicting the myocytes? Okay, we'll go to Haitham. Who else is there? Abir. Abir Al-Ghamdi?
Yes, doctor, I'm here.
Okay, can you, when you look at this graph and you think about the myocytes, it's supposed to depict the action potential of the myocytes, but there's something wrong about this graph. Can you pick it up? Yes or no?
I'm not sure actually.
Okay, any volunteers?
I think in phase 0, sodium should be high, not low.
Okay, yes, but it's actually, that's the movement after, immediately after. So actually the one I'm talking about is 4. Phase 4 should be increasing gradually until it reaches threshold. And that's the reason for atomicity. Atomicity and the heartbeat. Yes,
actually, there is 2 types of this graft. One related to SA node and AV node, which is mainly depend on the calcium and not depending on the sodium, and the other myocyte, which is depend on mainly on the voltage of the sodium. So this graft, it's correct for the other myocyte, but it's not correct for the SA node and AV node.
Okay, let me just make sure.
And the rest of the conduction system. This is
Actually,
also what yeah, تفضل.
Go ahead, Murtada.
Yes, I was just confirming what Hussein said. This is also what I've read, that in the conduction system, in the conduction system, there is this characteristic of automaticity where the baseline is always like a slope. But in the other myocytes, there shouldn't be any action potential generated without external stimulation.
Can I comment?
That's of course is not, that's not true, Murtada, because if you take the myocyte in the experiment, just a single myocyte, you'll find it contracting rhythmically, which is different from the rest of the striated muscle. This is the graph for striated muscles.
Can I comment on the graph, Dr. Farid? Or...
Okay, تفضل فيصل. فيصل ولا لا؟
فيصل, Dr.
Yeah,
I think the mistake is usually the sodium channels open when they reach the threshold. It's minus 65, I think. So that's the threshold where the rapid sodium entrance to the cell happens.
But for that to happen, we have to have an upsloping graft here, upsloping graft right there,
yes.
Indicating atomicity. It may be different from one cell to another. For example, the SA node will have the highest rate of atomicity, and that's why it will have a higher rate here. But the other muscles will have slower and then slower and then slower. So the ventricular muscle will not be flat as this, will be a little bit higher, but it will take long time for it to be activated. So it will give you about somewhere around 30 beats per minute or so on its own. Anyway, the reason I mentioned this graph here is for everybody just to make sure that you remember those 3 components. And those are the components that we use for cardioplegia. It differs from one type of cardioplegia to another, but just keep it in mind, and that will help you understand the cardioplegic. Anyway, ischemia is an imbalance between the energy supply and the energy demand, and this was coined by Buckberg in early 1990s, which is a very good measure for us to go with. There are 4 components of what the process after that will happen: either stunning of the myocardium or hibernating of the myocardium, necrosis of the myocardium, or apoptosis. I know it's a small print, but I'm going to ask one of the volunteers here, what's the difference between necrosis and apoptosis? Let's take one of the seniors, Murtada.
Apoptosis is a programmed cell death, and necrosis is unprogrammed cell death.
So both of them are cell death. What's the difference between them?
Apoptosis is a programmed cell death. Like it's genetically designed For example, if the cell is infected.
How does that affect the outcome? It will all have dead cells, right?
Yeah. So what's the question exactly? The difference and mechanism?
Is there a difference? Can I tell the difference between the two, between apoptosis and necrosis? If this was programmed, it means that the cells know about it. It does not alert the cells about any reaction, and therefore very important to know that there will be no inflammatory reaction with this. Okay? But this one will always have an inflammatory reaction with it. All right. Anyway, it's something for you to realize when you look at the microscope, under a microscope. Hibernation may take weeks to months to recover. Stunning may take hours to weeks. Luckily, we don't see much of these days for cardiac surgery, but unless if you operate on some of those acutely infarcted hearts. Again, the early development of cardioplegia for myocardial protection started in 1955 by Melrose, where he started looking at the reversible cardiac arrest using potassium concentration somewhere around 77 millimoles per liter. And this is where it will act basically at the very beginning of the contraction of the myocardium I'm talking about the ventricular myocardium. Potassium citrate was the one that was used, but it was associated with myocardial injury and heart and myocardial necrosis as well. And that's why we used to see many of these problems with those kind of cardioplegia. With a different cardioplegia and addition of hypothermia, we managed to improve the effect of cardioplegia and the reduction of the myocyte necrosis. But still, we still have problems with quite a few problems with the hyperkalemic solution only. In the next phase, in the 1960s, continuous coronary perfusion was used with electrically induced ventricular fibrillation, and that have worked okay for some patients. But then later on, 10 years later or so, Buckberg have shown and demonstrated that this will also result in endomyocardial necrosis, subendomyocardial necrosis of those patients. And he basically recommended at that time is to avoid ventricular fibrillation for using it as myocardial preservation in a way to be able to perform the cardiac surgery with temperature more than 32. In those 10 years, Shamway have went ahead and produced more protection, better protection with profound topical hypothermia. Cooley have experienced and coined the term stone heart, which we hopefully we don't see anymore. In the 1960s, Holscher suggested that using procainamide as well as magnesium chloride may give better myocardial protection, but it wasn't until Brett Schneider in 1960 described his solution, which the concept of we will go over shortly. The reemergence at that time of potassium cardioplegia with the St. Thomas group, which have based their principle on three things: rapid chemical arrest, use of hypothermia, significant hypothermia, it was 25 degrees, and the anti-ischemic agents. In that report, they have plotted a graph where they put the theoretical calcium channel activation and the theoretical sodium channel activation, and they have shown that hyperkalemia will work best in this window, somewhere between 10 to 30 milliequivalent. We started at the early times with 30 milliequivalents, and then giving the next doses of 15, so about half of that. But more and more recently, we're dropping that number 20 to 15, and even recently down to 16 and 8 milliequivalent of potassium. That, of course, reduces the membrane potential to the range which is reasonable away from the sodium as well as the calcium channels. Blood cardioplegia had different advantages. It has better oxygen carrying capacity, which supply blood and oxygen even to the ischemic cells at that time. And we give it frequently, of course. It has a substrate preservation, including whatever we don't know component on the blood, as well as the regular substrate we're talking about, buffering the pH around 7.4, and the free radical scavengers naturally occurring in the blood. And also it will maintain the osmotic pressure somewhere around normal. It has added cost to the system, tubing, etc., but also the blood that has been used, not maybe much for this, induced a sludge effect because of the blood and the hypothermia, and that can have created some problems, especially with microcirculation. And then, and also the oxygenator. And also every time we give cardioplegia, it's a bloody field, so we have to stop basically the surgery for the time being. Antioxidants and inhibitors, oxygen of free radicals production. The interest became very high in the 1980s as an answer to the problem of the stone heart. But of course, added to that was the calcium issues. The free radical, including superoxide and hydroxide radicals, hydrogen peroxide, the endogenous antioxidant, including dismutase, the superoxide dismutase enzyme, and catalases, were dysfunctional with hypothermia as well as within the ischemic tissues. So that time we used to use allopurinol preoperatively for patients. Metallic iron, like iron and copper, due to hemolysis, mainly from the suckers, may have helped some. Deferoxamine was also another material that have been used as an antioxidant. It inhibits the neutrophils activation. But later on, they could find a better solution for neutrophils by filtering it, and that would have reduced the Rayleigh effect on the lungs. Manipulation of the metabolism substrate, exogenous high energy phosphate. It has been added, creatinine phosphate have been added to the St. Thomas solution. Amino acids like glutamate, aspartate became very popular in the 80s. And glucose, as well as glycolysis intermediates, all these have managed to produce ATP in anaerobic situation, which may help with the substrate issue. So we're talking about optimal delivery of cardioplegic solution. Should it be a single shot or repeated shots, intermittent versus continuous, cold versus warm? You probably have heard all these terms: antegrade, retrograde, crystalloid versus blood, depolarizing versus hyperpolarizing, or the same applies for intracellular and extracellular type cardioplegia. I'm going to go ahead here and ask one question to one of the guys, and it better be one of the seniors. So let's see, Hytham, can you tell us answer some of the questions about cardioplegia? Hytham?
Yes, boss, again, there was a question.
So the question is, what's the pressure that you use to give cardioplegia?
The pressure usually depends on the route of the delivery, if it is antegrade or retrograde. For example, in the antegrade, in the antegrade, you can 100 to 150, you can reach also 200, but as much as you go higher, that will affect the delivery. For this is for antegrade, but for direct cardioplegia, you need to go for lower pressure, not to cause the destruction of the coronary ostium. Retrograde, you need to go, actually retrograde this lower pressure as well.
Do you have a number, figure?
Retrograde, you must not exceed, there is many literature, but usually not exceed 35 to 40. the pressure on the coronary sinus.
Yeah, and in the Antegrade, they usually talk about somewhere between 50 and 80, maximum 100. So if you reach, if you go above 100, you start worrying what's going on there. But what's the volume that you should give?
The volume it have no, يعني the volume you can even in the literature 150 to 200. Some literature you can even go more higher volume, but you need to watch the pressure. Yani you can go up with the volume, but you need to watch the pressure actually.
What do you mean by 100 to 200?
No, 150 to 200 ml per minute.
Okay, but total volume is?
Total volume, it's depend on the patient weight, but usually roughly in the adult, you can give like 1 liters initial dose, or 1.5, depends on the weight of the patient, to have the initial cardiac arrest. This is for, if we are talking about blood cardioplegia, so initial dose usually 1 liter, 1.2 liters, depend again on the weight of the patient.
Okay.
Actually calculated to be the calculation of the volume, it's usually 20 to 30 ml per kg as a total volume.
All right, so I'm going to show you some of the other pictures here. This is a group of trainees in Canada. Do you recognize any of those faces?
Yes.
Okay, there are 2 residents from King Faisal doing their residency now in Canada. But when I was looking for the different kind of cannulas, their picture popped up. So I thought maybe it's nice to show it to you. These are the different cannulas that we use. This is a regular retrograde cannula with a pressure monitor, which just like Haytham said, we try not to exceed 40. We usually have a very good waveform using this monitor to make sure that this catheter is in place after digital palpation in the coronary sinus. Direct cannulation of the coronaries occasionally might be mandatory with different kind of cannulas. These are some of the cannulas that we use in the neonates for TGA, for example. This one we can use for the grafts to infuse cartridges in the graft, which is the heparin, basically metal tip for the vein grafts. These are the different cannulas we use for direct cardioplegia into the coronaries. And this is the root cardioplegia with a vent attached to it. So we can use this also for this line for venting the aortic root. These are different type of direct coronary cardioplegia cannulas. Okay, so what are the different cardioplegia? Yes, go ahead. Who's this?
This is Khalid Al-Taibi. Can I just comment on the pressure on cardioplegia, antegrade or retrograde? Usually we don't have a difference in pressure and retrograde because there is always a transducer at the tip to measure the cardioplegia. So it's all in all boxes from 20 to 40. But the difference is, as happened today between you and Dr. Haytham. Haytham said like 100 to 200, and you said 50 to 80. Actually, it's the pressure is 50 to 80, but sometimes we ask the perfusionist to go to like 100 or 200 because, you know, to overcome the resistance through the lines and the cannulas that we are using. So I found, I learned a very small trick here that I think it's very useful, especially when we are giving a direct osteal cardioplegia. Just when I'm flushing the cardioplegia in a outside in a gillipot or a kidney dish. So I could ask when it's outside and just I'm flushing the cardioplegia through the line and my direct cannula, I could ask the perfusionist for the pressure right now in his line and the plegia. So this pressure will be the wasted pressure from outside. So if he told me like 100, well, I'll ask him to go 180. So I know that the pressure on the coronary will be around 80 millimeters mercury. Thank you. Thank you very much.
Thank you for the comment. Okay. All right. So what are the different types of cardioplegia solutions available? Big question, but in general, for our current practice, there are 2 types. It's either blood cardioplegia or crystalloid cardioplegia. crystalloid, we can give the long-term or the short-term cardioplegia. Even the blood, excuse me, even the blood cardioplegia, we have also the del nido cardioplegia, which can last for 2 or 3 hours easily for most of the patients. So we have the custodial, which are based on the histidine as the main buffer in that group. It also depends very much on the very low sodium content. So it's actually hyperpolarization. It allows the hyperpolarization and will give the patient quite a bit of space to use the buffer, because the osmolarity of the tissue of the solution will be very low. Therefore, we have enough room, enough space to use for buffering system. The low sodium solution will prevent the fast inward current is inhibited. And that's the main issue. That's the main function of this. It will arrest the heart in a hyperpolarized state. It was described first by Bonhoeffer in 1960. And it also demonstrated a very important point. It has the lowest energy consumption of those hearts. Excuse me. Right. Another thing about this custodial, it has, because of the low sodium that it has, it will never lead to calcium paradox phenomena, the stone heart. And this slide here explains how that happens. There's a natural law relating the sodium and the calcium ratios. It's 1 to 10, and therefore, if you have the ratio of the sodium down to 1 to it's almost 15, down to 1 to 10. Therefore, the calcium will be much lower, and there is no chance that this patient would have the calcium paradox phenomena. And therefore, with the custodial, now that with, of course, with some caveat, you have to have giving the custodial in a very good situation, very good environment, very good flow, and you have maintained the no perfusion of the myocardium for quite some time through the collaterals, for example, or adhesions, etc. So with that concept, you will not see the stone heart with those patients. Now, something good about the custodial that you can give it only once. You don't have to give it more than once. The problem is for a surgeon who uses custodial and then, let's say, an hour in the operation, the patient starts showing some fibrillation. Would you give the second dose? Again, question for the seniors. Let's see, Hussein?
I think yes, you can give the second dose.
Okay, Haytham?
Yes, can be given.
مين كمان في seniors؟ أنا ماني شايف الأسماء هنا بس first name is showing, but I don't know the rest of the names. Who's there? Okay.
I think if there is an activity, I will give. Othman is there.
And that's a nightmare for the surgeon, because you may have to actually give another dose, which is not recommended to be given. But the reason I think it's better to give it is that those activities may reflect inadequate cardioplegia protection at the first time, either because of the presence of collaterals, and sometimes we do surgery and redos, and you have blood flowing through the coronaries, so you actually flush the cardioplegia situation. The patient may recover from cardioplegia sooner than the 3-4 hours that the time is given. Another thing is that at the time of surgery, it's not like the heart transplant. For example, you transport for 3-4 hours safely. You're actually putting the heart under the light with intense heat developed on the surface of the heart. So the heart actually may be not cold enough for you to proceed. So I personally get worried, and I understand, yes, it's against the recommendation, but I would go ahead and give the second dose if I see significant fibrillation.
You will
Going
give full dose?
Sorry, who's this?
How much you will give?
I would give the same dose or half the dose. Depends. What I would do is I would ask the patient, the perfusionist, to help and start infusing the full dose. But if I watch the heart and see the heart completely stop early on, I would not proceed for the full dose. Maybe half the dose is enough. Okay, so low sodium in the solution, about 30 milliosmoles. That will give you quite a bit of room between 30 and 300, which is the normal, and that's how we fill up all that space with the buffer materials that we use. For example, we use in this case we use histidine, and if you look at the component of this custodial, it has about 180 milligram there per liter, so it's quite a bit of dose of the histidine. Histidine can be converted to carnosine, but it's not. It has not been shown to be effective. Actually, it was worse results with the carnosine compared to histidine. And I'll show you the slide here. This is the endothelium under electron microscopy showing the histidine effect, and this is the carnosine. It's the totally destroyed endothelium. The histidine is the better preservative buffer that we can use. And this is the rest of the component. You can see mannitol also is part of the component. So all these are components that will increase the osmolarity up to 300. But remember, we have quite a bit of room here to use all these good medications, including magnesium and including ketoglutarate and mannitol, tryptophan, and all these. There are small studies here and there showing the effect of all these amino acids effect and the mannitol effect on the heart. The way histidine is converted to carnosine is through combination with the beta-alanine. In this slide, we can see the difference between the arterial oxygen and the coronary sinus oxygen as you give the Cardioplegia solution for how many minutes. And if you reach this level, which is here, which is about would translate into 1 ml per 100 gram consumption, it's about somewhere around 6 minutes. So most of the time we give them the Cardioplegia with that pressure and with that temperature, cold temperature, but also for enough time. We don't want to stop early on as you go on until this curve flatten after 6 minutes. The results have shown that there's no more benefit of giving it to 7 minutes. So many times we just give it and the heart usually stops somewhere around here, around 3 minutes. Okay, that's of course another question that will come up to the group, but this list I showed you earlier in fragmented slides showing that's a postoperative low output, low cardiac output syndrome, and these are the pathophysiological reasons for that. For example, the creatinine phosphate will be dropping, the ATP will be dropping, the substrate will be dropping in the heart, the myocardial edema will be increasing, stunned myocardium, and so on and so forth will give you this. In addition to that, in the postoperative period, there's also the coronary flow is reduced because of the edema as well as because of the loss of the coronary vasodilatation. Autoregulation effect. Intracellular edema will be increased. So all this will add to the problem of low cardiac output syndrome. And you really, as a cardiac surgeon, you should be able to be versatile in how do you manage, how to prevent, and how do you manage this related to the cardioplegia and myocardial protection. Hyponatremia have been alluded to because of this custodial effect. But then in their conclusion, people have shown that, yes, it may happen, but it may be more dangerous to try to correct the hyponatremia after cardioplegia. So It does not require any correction. It usually corrects itself within the next few minutes, even many times before you leave the OR. There's a very nice commentary here on del nido cardioplegia. Can we or do we need to prove the benefit? The debate on this idea has been going on since the 1950s. It's not resolved. Ultimately, a clinical meaningful difference in myocardial protection strategies remain difficult to prove. This finding will allow each one of us, each surgeon, to choose an optimal strategy between this and this. I and most of my colleagues in King Faisal will still continue to use the custodial solution. Somebody else commented also on this about the cardioplegia solution. Should it be this or that? And it's basically the dealer's choice. Their comment there at the end, performing an expeditious, efficient, technically perfect surgery is probably much more important than the type of cardioplegia. But I can tell you from my little experience about custodial, I don't see any more low cardiac output with this. I don't see a need for intra-aortic balloon pump. I don't see, I see much less numbers of patients who's having, cannot come off the OR without major help or major inotropes. So I think it's a very good cardioplegic, cardioprotective technique that we can invest in.
And Dr. Farid, I think in our, can I just comment on this?
Please, go ahead.
We are using in our center, in Bristol Cardiac Center, the NADO for the last 2 to 3 years as a standard cardioplegic solution, and we compare it to intermittent cold blood cardioplegia. We found out that it's significantly shortening the cross-clamp time and bypass time, and as well as that the troponin level and need for inotropic support post-op. So this is from our experience. And as you said, there is no standard cardioplegic preservation solution for. It's just a surgeon preference.
Okay, of course, what you just said is totally contradicting what I'm showing on this slide. But I'm going to ask one of the seniors again, who have worked with the NIDO. Who wants to answer that? Who wants to jump in?
I want to comment also, if I may.
You may comment, and I will ask you the questions after that. Go ahead, Murtada.
Okay, regarding the choice of cardioplegia, I'm referring to the 2019 European guidelines. Here they recommended as a class 1 that that I will quote it here. It is recommended that patient myocardial protective strategies to be used based on clinical condition and procedural complexity, rather than use of fixed institutional cardioplegia solution. So when you said that usually in King Faisal you use the custodial, and in our center we use the NADO, I think yes, it's good to be familiar with one strategy, but in different patients, other types of cardioplegia might benefit them more. Here in the same guidelines, they stated also, or they recommended as class 2A, level of evidence B, that blood cardioplegia should be considered in selected patients to reduce hemodilution, bleeding complication, and transfusion requirement. And this recommendation was based on meta-analysis of thousands of patients and meta-analysis including many RCTs comparing blood cardioplegia with crystalloid cardioplegia, and with all and in all these RCTs, they didn't find any significant difference in mortality and postoperative MI and major things, but in terms of bleeding complication, transfusion requirement, and also in some the trials they found benefit of blood cardioplegia and decrease low cardiac output syndrome postoperatively. And those patients, the selected patient who would benefit from blood cardioplegia, were specified as patient with anemia, low body surface area, chronic kidney disease, or patient undergoing complex procedures. So this is the statements in the guidelines, and that I'd like to share it with you all.
Okay, so but when we say this institute use this, for example, in King Faisal we use that, mainly it reflects that most of our patients are the complex type, and this is the one we would prefer, the one that will take 3-4 hours easily on bypass with cross clamp. So maybe that's the reason. I don't want to say that's the only reason. Yes, there are publication here and there, and you'll find some biases also in the publication. My own bias is that I used blood cardioplegia until about 10 years ago, when I was convinced. I was on a trip to New York, and I found that most of their patients and the perfusionists are using custodial. And I said, why not? And to tell you the truth, I saw in my hand a big difference. But you'll always find people leaning toward this and that. Actually, one of the papers that I came across was saying, well, actually, the blood cardioplegia is good because it gives 20 minutes cycles with break of 5 minutes or so to the surgeon, so he can rest his mind and reset his thoughts and kind of basically come fresh with new ideas when he go back to the actual
Dr.
procedure.
Farid, if I can interrupt you here, because I have a question in my mind regarding the blood cardioplegia.
لحظة
when you
ما كملت الأسئلة حقتي ولا كملت بس اتفضل يلا معلش go ahead.
لأن أنت دكتور قلت إن it gives the surgeon a break. I have this question الآن إحنا when we give blood cardioplegia we give it through the pump and then through the oxygenator and then through the cardioplegia, and then it will mix with the cardioplegia solution. So it contains an oxygenated blood, right? So during the time that we are giving the cardioplegia, in case of intermittent doses, so say we give like 3 doses and each dose like 3 minutes. So this is like 9 minutes, right? Can we consider this 9 minutes not included in the total ischemia time?
No, it's actually counted in the ischemic time. So nobody will go and subtract how much time you took for the cardioplegia. It's actually because
I know.
Even though
theoretically, yeah.
Yeah, but the reason why you cannot control, because even your cardioplegia, in the best form, in the best scenario, you're still dealing with an ischemic myocardium. At that moment, the myocardium is not totally perfused. It's not, even with the antegrade, even with the retrograde, and they have shown that antegrade perfusion does not perfuse the whole myocardium. Retrograde does not perfuse the whole myocardium. Combination is better, but even combination is not as good as normal beating heart. So still, it's a ischemic situation, and you cannot exclude it. But I'll go back to you. I have a couple of questions for you. First of all, have you used the Delnido?
They use it regularly in the Sultan.
Have you you have used it, right?
Yeah.
And
the surgeries that I attended, they use it. Yes.
Is blood a component of Delnido?
Yes.
I'm not sure.
Yes.
Yes, it's a component.
Yes. But it's different than blood cardioplegia. The component actually it's 4 to 1. The one is the blood.
What do you mean? What do you mean by 4 to 1, Hussein?
So every 4 ml of crystalloid, you will add 1 ml of blood.
And how is that different from blood cardioplegia?
Blood cardioplegia, you have 4 ml of blood, and the crystalloid is 1.
Okay, and that's again for everybody to recognize. Anyway, let's go back again.
And just a small comment, Victor. Yeah, I think you know Joseph Lamellas, the famous minimal invasive surgeon in Miami, in the United States. He's using something called modified Delnido cardioplegia, which is 1 to 4, means 1 ml of crystalloid to 4 ml of blood. So Delnido, there is like 2 types of Delnido.
So again, it's with this blood in this picture, you may have to consider that as a part of the bloody field if you are in the middle of something. Anyway, we'll go ahead. Thank you all for the comments. We'll continue now. Energy consumption and intracellular accumulation of calcium is a possibility with the needle. And therefore, you have to be careful. Yes, we use lidocaine in this combination, in this solution, the needle. We use lidocaine to block the sodium channel to prevent the intracellular calcium accumulation, which will lead to, which may lead to stone heart, but it does not rule it out fully. So that's one of the issues here. Not only that, but in this study, which is a huge study, they have found that there's no difference, and this is to answer your comment, I don't know who made that comment earlier, but no difference in myocardial enzymes, postoperative inotrope support, atrial fibrillation, hospital and mortality between the two groups, between the Delnido and the blood cardioplegia. In adult cardiac surgery, myocardial protection with Delnido or conventional cardioplegia solution yields similar short-term outcome, and this was published in 2017. Ischemic preconditioning, and this is totally different from cardioplegia now, totally different. It may be used along with cardioplegia, but it's a concept. I have not practiced it. It's been there since the 60s. There are some people who are advocate for it. They have shown evidence of as it being the most powerful indigenous mediated form of myocardial protection. It slows down the ATE depletion. It limits the acidosis. It prolongs the ischemic time that you can handle, the patient can handle, or the heart can handle. It may be mediated through the adenosine. It's a very adaptive, it's an adaptive mechanism that has basically built in the mechanisms of the heart to resist and subsequent long period of ischemia. Interesting concept, we have not used it. They use it like, for example, they go to the arms or to the legs and develop ischemia for some time, about 15 minutes or so, reperfuse. And then again, for the heart, some people have done similar things like this with slowing down the pump for some time and going back again, slowing down and going back again a couple of times, sub-ischemic times, or even putting a clamp and basically subjecting the heart to some ischemia and then reperfusing it. All these maneuvers, the distal as well as the cardiac preconditioning, have been shown to be effective. It did not gain popularity in many places, in many surgeons' hand, but you should be aware of the possibilities and the potential. Maybe someday it will come. Okay, so what are the causes of failure of heart to arrest?
Doctor?
Yes?
There is also, yes, you know, I like the guidelines. In 2011, American guidelines regarding CABG, they mentioned the use of ischemic preconditioning as class 2B because of lack of evidence of its benefit.
But class 2B is not a bad evidence, huh? Class 2B
yeah.
is reasonable to use. So, I have no experience with that. I have not used it, but I know some big centers utilize that technology and that maneuvers. Some of them use the distal ischemic stimulus, like a blood pressure cuff on the arm or on the leg. Some people use it on the myocardium itself. So again, I don't have enough experience to judge on that, but you should be at least aware of it. And how is it
interesting?
All right, so what are the causes of failure to arrest the heart with antegrade cardioplegia? Let's take one of the juniors guys, Hudayb Abdullah.
Yes, Doctor.
Can you please answer?
Okay, collaterals, stenosis, and some. First of all, the cardioplegia needle might actually not in the right place. It's actually might be dissecting. If there could be some collaterals.
What's the most important clinical scenario that leads to this this issue?
Cross clamp is not fully on.
Okay, but that's usually, I mean, I expect you after doing 1,000 surgery, you know how to put a cross clamp.
Yeah. Yeah. What do you mean? Like, I would
Give
say
me the
like
clinical scenario that results in this.
the most common scenario.
Severe aortic regurgitation.
Okay, that can be counted, but you should be aware of that before surgery. Yes, that's true. Another thing that you should be aware of, you may have a faulty.
Yeah, the content of cardioplegia itself.
Who's this, Hussein? Yes, Hussein, that's true. That's absolutely true. Especially if you are the one who's making the cardioplegia solution in your institute. It could be a faulty bottle. So you have to change the cardioplegia, okay?
And also severe coronary artery disease, osteal.
Okay, so how, I was gonna ask Abdullah again, you mentioned something about dissection. How would you know that this cardioplegia, you're facing dissection with the cardioplegia?
High pressures and
how would you know that there's high pressure?
you compare it to the pressure. So how much he's giving and how much. Actually, I forgot, but I believe as the normal pressure you would say, and you compare it to the normal pressure. If it's too high, you would suspect that, and the heart is not arresting, and some edema around the aorta.
You may see it, yes, you may see it, but it's usually it's the complaint of the perfusionist with the alarm system going on. Actually, the machine will stop. It will not deliver anything with higher pressure, so therefore it will stop, and he will tell you that cardioplegia is not going. We have high pressure alarm, because that's the alarm that will save the patient. That's the alarm that will stop or prevent the dissection. Okay, we'll continue now for the other question. I've got a few list of some practical questions here. What myocardial protection strategy are available for patients undergoing redo cardiac surgery with a patent left internal mammary artery? Let's say redo aortic valve surgery. Let's take one of the seniors for this. Hussein?
You can do peripheral cannulation, and you cool the patient. And if it's easy dissection, you can dissect around the mammary and put bulldog. If it's not easy, you can do it under hypothermic circulatory arrest. And to minimize the manipulation of the vein graft, or you not manipulate the vein graft at all if it's patent. And you can use, if it's easy for you, you can use retrograde cardioplegia.
So we're talking about patent lima to the LAD, and you're trying to do an aortic valve surgery. What does that have to do with the vein grafts?
Because you will dissect the ascending aorta to have area to do the aortic replacement.
Yeah, but then I don't. Do you perfuse the coronary there? You mean direct perfusion of the vein grafts through the aorta?
No. You will do, if you have to do, you can do it retrograde cardioplegia.
Okay. So if you have a retrograde with a patent lima, how does that work?
So actually, you can leave the lima and you go down with the temperature, like 32 or 30 degrees centigrade, and you give antegrade and continuous retrograde and do your valve. Other tricks you can do. You can just put a bulldog on lima in the middle or in the proximal parts during you are doing the AVR as well.
So
but
would you,
these two methods been mentioned.
Okay, would you
Can I?
Murtada, go ahead.
I think the safest, in case of patent lima to LAD, I think the safest option is to leave it and just give more frequent doses of cardioplegia with some cooling. I think that's more than enough.
ايش رايك يا هيثم في كلام مرتضى؟
No, but because يعني okay, intermittent what mentioned if you leave it, what's been mentioned in you give okay antegrade initially to the arrest to arrest the heart, but you need to give some sort of continuous perfusion, especially the retrograde. The retrograde will protect more the LV, which is the LAD territory. Hypothermia will also improve that, but just to depends on intermittent antegrade. This is I never read it. You need to go both antegrade and continuous retrograde while you are doing your aortic valve, or you can go proximal for the lima and put a clamp there. But if there is a lot of adhesion, you go down with the temperature, continuous retrograde, intermittent antegrade.
It's depend on the patient. You can do it. You can clamp the lima, or antegrade, retrograde, or even circulatory arrest.
Yeah, of course.
You have all these options.
Unless you are in very advanced center where the cardiology can put balloon to intermittent include the lima.
Yes, this option I like, but I would use any option except manipulating the lima, even arrest. But I think manipulating the lima is not recommended. I think so.
Okay, so back to you, Haytham. Is it necessary to give retrograde cardioplegia on those patients that you have used antegrade with a patent lima and they arrested the heart? Is it necessary to give retrograde?
No.
Okay, so
I will say yes.
You keep mentioning it. It's necessary, but it's not necessary. أنت تقول yes, Hussein?
It will help arresting the heart because it's very difficult to arrest the heart with patent lima. Because the heart will still rewarming.
Is it necessary?
The question, it is necessary as like this, the answer is no, but I will prefer to give it because I want to prolong to protect the heart more, and I want to prolong the period that I need to give antegrade. But necessary, no, but once the heart starts to contract, you need to give frequent antegrade. طبعا of course, if you go more down 32 or 30 degrees centigrade, you will have more, with a cold cardioplegia, you have more period for arrested heart.
Okay. And that's usually differs again from one surgeon to other. My personal technique is to use retrograde for all aortic valve surgery. Anyway, but that's not necessarily the rule. Huh? Let's come back to you, Hussein and Haytham. Murtada says he will avoid dissection of the lima to clamp it. Is that a good statement, or is that you disagree with that statement?
I agree with his statement. If dissecting the lima in his hand will make a lot of damage to the lima, don't do it. But if you are
in my hand or in any hands, it's not recommended.
Okay, Haytham?
No, I don't disagree with the statement, but I don't know from يعني Murtada keep mentioning is not recommended, is not recommended. Yes. So if I mention something like that, if I say it's not recommended or it's a must, like when you ask me is it necessary, no, it's not in the continuous retrograde. I mean, when a statement like it's not recommended, I don't, yani, this only the disagreement about this statement, because
well, and this is where it comes from your reading of other people's experience. Even in the best hands, there have been incidences where the lima have been injured because of an attempt to dissect it and to clamp it. So the recommendation is do not dissect the lima. Okay, if you do that, you have a chance. Let's say the chances in your hand is 5%. That's 5% too much, because you're not going to be seeing the same 5% danger when you give the cardioplegia other way and keep the lima patent. So in general, leaving the lima patent with retrograde cardioplegia, with another form of cardioplegia, or frequent cardioplegia, or with hypothermia. In addition to that, that is much safer for the patient. If the edema is injured, usually those patients do not do very well, and they end up with very high morbidity and mortality.
For
So
that, we said in the beginning, it's depend on the dissection. If it's easy, you can do it. But if there is any risk, better to avoid.
Okay, ما في حاجة اسمها easy. It's people with great experience, high level centers. They end up with injuring the. So unless if it's, for example, okay, it's very obvious that this is the area of the lima and you can see it pulsating, and you can put a clamp without dissecting it, putting a clamp, and yes, you can arrest the heart, fine. That's okay. Otherwise, you should not attempt, because even in the best hand, there's a danger of damaging. And with that danger goes the mortality, and mortality very high. Anyway, so we'll leave it.
So you will go only with, you will go with antegrade and retrograde with
moderate
temperature around 2 or 30.
I usually keep my patient around 32. In this case, I may go to 28.
Okay.
All right. All right. So what technique is available for myocardial protection during off-pump coronary artery bypass surgery? Now, we just heard earlier from Khalid saying that this guy with minimal invasive, he preferred to use Del Nido with a modified Del Nido technique. Okay. But in general, we do the off-pump surgery without cardioplegia, without cross clamp. So how do you protect the heart in that situation? Let's start with Micarta.
Okay.
Me?
Yes.
Yes. Okay. So during off-pump, if we manipulate, for example, the LAD, we will occlude the vessel, and we can use a shunt to keep perfusing distal to our anastomosis.
Shunt in general will help. What else?
We can use intracoronary shunt, and also schema precondition, and also constructed lima LAD anastomosis the first graft.
And then
we can position the. Yeah, and we have to take care of the hemodynamics also, and positioning the heart in a way that will not prevent the coronary supply, something like this, and some cooling maybe. I'm not sure. I never read about it. This is just.
What do you mean by cooling?
فلسفة.
لا تقول كلمة
cooling.
So if you
cooling with a blanket. Actually, I'll be very honest. I never read about myocardial protection
regarding Murtaza. Would you say cooling? Sorry.
Let's go to Hussein. Hussein, you had some comments there.
I will go with using of intracoronary shunt and doing lima to LAD first. And during the manipulation of the heart, you have to alert your anesthetist, because patient will develop the hypotension when you are elevating the heart. You can do snaring only on the left side, and don't hang the pericardium on the left side, so patient will not go in hypotensive when you are manipulating the heart. And some surgeon, they do beating on pump. They will not arrest the heart, but they will use the pump without arresting the heart.
This is off pump we're talking about here. Okay, Haytham.
Okay, regarding off pump surgery, the main principle is to protect the heart. The first things is you look before you go into the surgery, what is the area of great danger or jeopardy. So that territory need to be revascularized first. Many times it will be the area of LAD, but it's not necessary. So first things, you revascularize the area of great ischemic burden to deliver blood to it. One. Second, it's been mentioned and emphasized to use of intracoronary shunt. And this is also one of the critique in the Ruby trial. Why in the Ruby trial off pump? Because they weren't using the intracoronary shunt. So this is the most important two methods for cardiac protection. Hypothermia, of course, when you mention that I want to use hypothermia, that means you need active cooling, which pump. So this is not off pump. And if you even by any means use some cooling, that will lead to fibrillation. So this is out of equation. But the two most important principles to revascularize the area at rest, then intracoronary shunt.
Somewhat more posterior and leftward in the aortic arch than the usual.
Hello?
We lost somebody who was talking to us. Russia, somebody by the name of Russia. Anyway, hopefully we'll get her back shortly to have a comment. Go ahead, Russia.
أيوة دكتور.
Occurs with the developing left lung capture, this arterial supply of the lymphatic system.
Again, we missed him again. Anyway, I don't know who's that. Maybe it's Khalid with his poor internet connection. Is it?
Maybe.
Anyway, two major for each one of you guys. You should really read about this because yes, we don't use this technique very often, but it's a question for you in practice, and some of you may decide to take it. There are two other issues that we should think about, which is medication and anesthetic used. So please read about this topic because it's very important, very pertinent to this particular issue related to myocardial protection.
Yeah,
Okay.
regarding anesthesia, Doctor, it is a lot of, it is, as I mentioned these two things. The other thing, especially if you want to, for cardiac protection, when you are doing a right-sided, the VDA or the RCA, in adjacent to using a coronary shunt, many surgeons, and it's been mentioned in the book to you to put a pacing wire, because while you are doing revascularization of the right system, complete heart block can develop, especially in any area of interrupted perfusion at that area when you are doing. So you need to be ready to pace the heart, and you are aware the anesthesiologist about this. And the anesthesia rule is of great importance in off-pump coronary artery bypass, because of all the medication, the preload, positioning of the heart. They need to give more volume. Sometimes they need to use inotropic support.
Yeah, and they can use something to reduce the heart rate.
Yes.
Yes.
It's very important for them to use that beta blocker, Ismilor, as well as the vapor, anesthetic vapor they use, which is the Sufenta, I think, isoflurane.
Sevoflurane.
Okay. Yeah. Anyway, the last question in the group is, how do you manage persistent fibrillation after you remove the cross clamp? So you remove the cross clamp, the patient is fibrillating. You try to convert him, you cannot. Of course, there are issues that you should be dealing with. Is it an embolism? Is it myocardial protection? Is it something related to, do you have to cardiovert a few times? It's not effective. Is it the paddles? Is it the electricity? And so on and so forth. But there's, at the end, let's say you try this for 3 minutes, the patient's still fibrillating. What else can you do in that situation?
You go back on pump and let the heart recover more.
Okay, so you're on pump, the patient's still fibrillating.
And you said we already.
Hussein?
Sorry.
So, first of all, if you face heart fibrillating, you have to defibrillate. If the heart is unable to come back, you fibrillate again. And the third time you will give lidocaine and or amiodarone, and look for the cause. Maybe distension, maybe air, maybe electrolyte, maybe poor oxygenation, hypothermia. So decompress the heart, improve the oxygenation, correct the acidosis, correct the potassium, and look for anything ST segment in the monitor. Do echo if the T is available, and correct all of these, then defibrillate again. If you cannot, just go on pump.
Can I interrupt you?
Yes.
الحين طيب the heart is fibrillating now and distending. We are off pump now. So for how long we will يعني
And that's the
continue looking
question.
for causes and correcting causes?
That's the question.
How long it will take for you to look to the monitor to decide if there is ST segment elevation or not? And you'll ask about the potassium and look to the heart distension. This is the more important three things to do. So usually it will take a few minutes. Let's say less than 1 minute, 2 minutes.
Okay, let's say it's 3 minutes and the heart's still fibrillating. The same.
You will go on. You are on pump. You will arrest the heart and clamp and arrest the heart.
Okay, so basically you can clamp and give cardioplegia again. Do you have a okay? Yeah, I think that's reasonable. A few minutes of looking around for different reasons. You cannot find out the answer. You already tried to shock him 2 or 3 times. Clamp the aorta again. Deflate the heart or vent the heart very well. Give the cardioplegia. And
do we have to clamp, doctor, and arrest? If
well,
we just go back on bump and
no, you don't have to. You don't have to. Occasionally, I have used personally cardioplegia in the root, and assuming that but I don't give a very large dose. Remember, those days we used to use the potassium-based cardioplegia, the blood-based cardioplegia. It's not the same as the custodial. So the custodial may not arrest the heart in this fashion. But if you give the high potassium one, yes, it may arrest the heart without a cross clamp. It's a potential, but also it has a drawback of possible. We mentioned that earlier. High potassium will lead to some myocardial necrosis, and at this critical period, the patient is still ischemic. The myocardium is still ischemic. It's just barely coming off bypass. The calcium issue is on board, so it's not an easy decision. I would prefer, if you really have a sick myocardium, let's say you're not doing an ASD, you're doing a very poor myocardium with a valve and cabbage and things, it's better to put the cross clamp and arrest the heart completely, deflate the heart, look for all the reasons, look for the air in the coronaries, look for this and that. And that will probably give the patient the best chance to come off.
So, Dr. Farid, when Murtaza asked about the time limit before you cross clamp or arrest, I said 1 to 2 minutes. That's roughly come from my mouth. And you said 3 minutes. It's 3 minutes, or do we don't have time limit to cross clamp again?
If you go back to the old studies, yes, you can leave the heart fibrillating for some time, but it will have a very high oxygen consumption rate, as well as the ischemic insult will be higher. So it's not a good situation to leave the patient in. And the longer you leave the patient in fibrillation, the more difficult to get him back into reasonable rhythm that will have some pulse and ejection, etc., cardiac cycle.
So from the guideline or your experience, do you have certain number, fixed number, red line to not cross?
No, but usually people will say not to cross clamp, you mean?
No, not to cross the limit or the time.
Okay, no. There is no specific time, but I can tell you, many people will feel very uncomfortable leaving the heart fibrillating more than 2 or 3 minutes. I would personally do something about it, either re-clamping and cardioplegia within 3 minutes. Is that the only measure? No, I usually go with the cardioversion once, cardioversion twice, maybe some medications. Maybe I give him a dose of higher dose of magnesium and potassium. That will take usually the 2 minutes or so. I will help the patient with manual compressions to avoid any distension if there is any evidence of that. Keep the vent on. but I will not be reluctant to put the cross clamp on earlier, especially if the patient is having a sick myocardium. If it's an ASD, I can tolerate that a little bit longer, yes, but not the.
You
Okay.
you will give potassium?
I do give potassium, yes, not since I use the custodial, let me put it this way.
Okay.
Since I start using the custodial, I have not faced this problem. Maybe once or twice in the last 10 years that I had fibrillation persisting for more than 2 or 3 cardioversion. I really don't recall many of those bad incidents anymore. It sounds like a distant memory from the old days of blood cardioplegia. So, but if you do use blood cardioplegia, it's easy to give the potassium. Just give it another dose of cardioplegia in the root.
Mm-hmm.
No conflict of interest with custodial company.
Well, I'm thinking, should I buy stocks now or?
طيب دكتور آخر سؤال لو سمحت.
All right, last question.
Doctor, do you prefer any type of cardioplegia for heart procurement?
We use the custodial all the way, almost in every heart. Now
cold.
We have. I'm sorry.
Cold, like a profound hypothermia, and custodial 4 degrees, or
yeah.
You use custodial, yeah. And okay.
Which is histidine type of.
We have warm custodial.
Yes. Anyway, so I was going to say something. You interrupted me. Now I forgot what it is. I'm just trying to think here. What was it? Oh yes. Currently we have now the new technology of recruitment of the hearts, which you can actually leave the heart beating with a special solution that will be nutrient to the myocardium, and you can leave it beating on a artificial circuit for another, they say maximum 24 hours. And therefore you can actually more or less turn cardiac surgery into an elective procedure, next day procedure. We have applied that. Yeah, we have applied that to it. We have it in King Faisal. We have applied it once or twice. Unfortunately, one of the patients we brought in, the heart did not look good. So we brought the heart in and we did cardiac cath on the heart. Not on the heart, and we found to have the patient was found to have severe atherosclerotic disease, so it was discarded. This is
you did it in the heart while it was in the box.
Yes. So yes, it's nice, but it's very expensive. It's 200,000 riyals for this cost, in addition to the regular trip that you go out with the team. So it's not. Hopefully, this technology will.
Money is not a problem for King Faisal, يعني ما في مشكلة.
والله شكلك انت يعني اليوم بتكلم اسهم ومش عارف ايه لا Anyway, so you have to be careful. Costs I think will come down. It may become the way for the future, just like the kidney and the lung programs. I think they are adopting it, and there is a trend in the world. This will definitely expand our donor pool, so we can bring hearts from further away and keep it in for longer, because we're limited with the ischemic time. If it's 4 hours, yeah, we do it with some and E, but then after the 5 hours, it becomes really effy. After 6 hours, it has a very high loss rate of patients, and therefore we are very reluctant to take it beyond 6 hours. Anyway, well, thank you very much, y'all. I think I enjoyed giving this talk. I hope if anybody have any questions, but people who do not remember the past are doomed to repeat it. I have quite a few references in this for this talk. I can share it with you if you wish. There are most of these have been shared already within the group over the last 2 years. I have collected those articles from 2017 onward to 2020. If anybody is interested, just send me a note and I will send it to one of you guys to distribute it.
Dr.
Any
Khouqeer,
questions so far?
I have a question.
Go ahead, Faisal.
In case of hypertrophied heart, would your strategy change for myocardial protection?
I would tend to use very aggressive approach in the antegrade policy. Higher perfusion pressure is, I think, is mandatory. I would give it a little bit longer. Again, I'm not sure really what else to expect other than to say this is a high-risk patient for myocardial protection. And to accept the fact that he may have arrhythmias after surgery, they may not be able to come off nicely with good rhythm. So those are the ones who will have fibrillation, ventricular fibrillation afterward. So the only issue here is to make sure that I have very good coronaries that I can perfuse. If there's any doubt, I would go, if this patient going for coronaries in addition, I would go for the direct coronary perfusion or graft perfusion in the meantime. I would definitely do retrograde if I'm using the blood cardioplegia. And cooling of the patient, cooling the temperature a little bit down, lower than normal. I usually go for 32 in many patients, but in this case, maybe 30, 28. And again, I say that without evidence, scientific evidence to support me. It's just a hunch, surgeon guilt feeling, let's say, or gut feeling, who knows. Anyway, we'll see.
Thank you.
Any other questions? I have a question for the, again, for the seniors. Hussein, what's the pH of the custodial?
pH of the custodial. 7.4.
Murtada, what's the pH of Del Nido?
I don't know. Sorry.
Okay, again, this is an important question for the seniors. If you are asked about cardioplegia, you're expected to know more details, including the pH value. By the way, for the juniors, I'm not sure who's there who can help. Let's say Abir, what's the pH stand for? I don't think she's there, right? Or is she there? Salboud, Ahmed?
Yes. For the acidity and for the acid and alkalosis.
Oh, pH, what does it stand for?
I don't know.
Okay, what's the, let's say Amjad, what's the pH of water? Amjad Barnawi.
Yes.
What's the pH of water?
Of water?
Yes.
I'm not sure, but the normal pH is usually 7.32 to 7.42.
That's normal people, right?
Yes.
What's the pH of the horse? No, anyway, so it's an interesting topic to know about the different pHs of different solutions.
pH for water around 7, pure water.
It is neutral.
It's actually, yes, it's actually 7. Okay, Ayat, what does it mean having a pH of 7? What's the concentration of hydrogen ion there?
Why I forget that for this information.
It's 10 to the power of -7 moles. Anyway, I think it's a very interesting topic to know the pH and the different pHs and different solutions, including normal saline and including lactate, ringer lactate. What's the pH of those? By the way, the pH of custodial is 7.02 to 7.25. The Del Nido is 7.4. Okay, y'all enjoy the evening. Have a good night.
Can you repeat the pH for custodial and Del Nido again, please?
pH, what do you think about going back and read about it? ايش رايك؟
لا عشان اتاكد منها بس.
I can answer.
Go ahead, please.
pH for the needle 7.4. About custoidal between 7.2 to 0.3.
7.02
02, yes. Sorry.
إلى 7.25. Okay. Alright. حتى هي لو سجلوها ما أدري حتعرفها بعدين ولا لا. حسألك إياها في الامتحان. Okay. أي أحد عنده أي أسئلة ولا شيء ثاني؟ Anybody have any questions؟
أنا ودي أسألك دكتور بس ما أبغى أخذ من وقتك يعني.
لا خذ من وقتي، أنا ما عندي شيء والله، بس كنت راح أشرب قهوة.
لأن صراحة ما فهمت بالضبط ليش why the custodial solution doesn't cause calcium paradox.
Okay, I can send you the article. I can send you the article that explained that very well. Actually, it was a lecture by very famous physiologist, and I think it's very good for each one of you to read it. It's already been sent to the group, by the way, some time ago, 2018 maybe, or early 2019. Anyway,
there is other reason. The calcium in custodial is very low. It's less
yeah, is that the only reason?
But that's not the reason they're talking about low calcium in the solution. It's actually having very low sodium is the essence, because it's if you have a low sodium, this means that now the ratio between sodium intracellular and extracellular sodium is maintained around 1 to 10, right? And the same for the potassium, the same for the calcium. So if you change the ratio of the sodium, the calcium will change. And as if you have changed, once you change the sodium from 150 normal 145 or 150 down to 30, then the sodium, the calcium also will have to change. The ratio of the calcium will also have to change, and it will change almost by 10-fold lower. And by having no calcium, no high calcium in the milieu, in the environment, in the extracellular fluid of the cells, therefore it will not go intracellular. It will not have a major influx. Mm-hmm. And that's one of the major criteria or major hypotheses about stone heart. There may be other things, but I tell you, from my little experience over the last 10 years, I was very happy as a person, as a surgeon. Now that's not science, that's anecdotal. But I was very happy. I have not seen very bad hearts after cardiac surgery. I used to see quite a few, and I used to put intra-aortic balloon pump, quite a few on those patients in the past. Okay, I don't see that anymore. Maybe we got better. Maybe our surgery is better. Maybe our anesthesia is better.
Maybe the residents assisting are better.
Maybe the assistants is better. After 2015 we start seeing residents, and maybe that's the reason. 2015.
السعودة لها دور كبير يعني.
تعرف في مريض انقذوه الدكتور حسين، الدكتور فيصل شمدين، سووا له immediate stenotomy، شو اسمه ده exploration في الاي سي يو، حطوه على الاكمو، والمريض دحين he looks very good، he start walking around وكذا. It's amazing story. الحقيقة I think it should be written down. But anyway.
Dr. Farid, this is one of them only.
Maybe it's the resident, huh? طيب. Okay. All right. Who else is there? Any questions? Anybody?
الله يعطيك العافية يا رب.
الله يديك العافية دكتور فريد.
يعطيك العافية دكتور.
يعطيك العافية.
الله يعطيك العافية دكتور فريد. شكرا لك.